Um, so you all should have the agenda, the slides, and the stuff from the prior presentation stuff. And so we're going to have Charlie Swanson talk to us. We allotted 40 minutes, so he told him talk up to 20 and to leave at least 20 for questions. And if he goes shorter, then we'll have more time for questions. And then we thought we should debrief the task force meeting, what people sort of got out of it and whatnot. And one of the things that came out of it for us, for me and staff, were that we should get Charlie here. Some of the comments that were made. And we'll try to come up with more questions for the Consumer Advisory Committee. And I don't know if anyone has signed up for public testimony, but when we get near the end, the staff will let us know. I didn't see any documents uploaded to the OHA site, so.
Yes, to our knowledge, no one has.
Let's turn this over to Charlie, and Charlie, I think you should give a one sentence, one floor of the elevator background. I think everybody got your memo that you sent out. And so we'll take it from there.
Okay, well, thanks for inviting me to speak today. I've been working on healthcare reform, single payer advocacy for healthcare for about 7 or 8 years. And much of that time, actually about 9 years now, much of that time I've spent looking at costs in the current system and what savings you can expect with the single payer system. And so I've been paying attention to this for quite some time. My background is as a physicist, so I'm comfortable with numbers. And so that's kind of where I fit into the healthcare advocacy movement, I guess. So I'm going to talk about my estimates of costs for expenditures, actually, healthcare expenditures in Oregon in 2019. And my estimates differ from Rand's substantially. And roughly there's sort of there's 4 different chunks of $3 billion or so where my estimates differ. One is that the $36 billion number that Rand put out actually that was at 2020, not 2019 estimate, does not include expenditures, as far as I can tell, it does not include expenditures for adult dental, adult vision, and a few other items that I'm pretty sure that we would want to include, the task force would want to include as benefits in a universal system. It also does not seem to include what are often considered expenditures by public entities, other state and local public expenditures. So a lot of what is spent by counties and other means not Medicaid and not CHIP. So all the other expenditures that are healthcare expenditures by state and local and county governments, and also expenditures on structures and equipment. And that's another roughly $3 billion. It also does not seem to include expenditures on private expenditures that are not from private insurance. And some of those are worksite health. Another little chunk of that is workers' compensation, the healthcare portion of workers' compensation. But a big chunk is charity care, and not the charity care that hospitals provide, but charity care that is funded by charities. It's not exactly clear what that total amounts to in Oregon, because I could not find recent data. But if you look at Oregon's share, per capita share of federal expenditures, it would be another about $3 billion. And then there's another amount that the other 3 billion, I'm not quite sure where it comes from, but it could be that that RAND report did not include the money that is spent by public employers in Oregon, so school districts, county and municipal government, state government, on their employers' health care premiums. So I'm not sure if that's where the other amount comes from, but that could be it. So roughly it seemed to me that the expenditures that RAND estimated were perhaps as much as $12 billion smaller than what actually happened in 2019. So that would then mean the revenue estimate that they had was too small also. And the 18 to 20 billion dollar that's revenue estimate that's on here is pretty reasonable. Part of it will depend upon what is considered new revenue. For example, the amount that is currently funded by Oregon taxes for public employee health care, if that money were used for the system, then that wouldn't be new revenue. If instead the tax structure was designed so that those public employers would save that money, then you would need to think of some other way to get that new money into the system. So that's on the order of $3 billion that could be considered new revenue or would not necessarily be considered new revenue, depending upon how you would design the tax structure. There's also savings that could result from a single payer system, and that some of those savings will come just because you have a single payer system, but some of them will depend upon the details of the system that's chosen. And a large part or a big part of that would come from choices made in paying providers. And so it's really more of a question for the provider reimbursement tag than it would be for this group, but they work together. So the 10% savings on overall cost is an optimistic one. It includes substantial savings, but also some increased expenditures because more people are going to get more care and you're going to pay for that. Some of that will be available because the providers themselves will have more time to provide that more care because the amount of time they spend on billing and insurance related activities will decrease. So the very recent December 2020 Congressional Budget Office report makes estimates of both of the savings that you could see just from reduced billing and administration by those who are paid to do that directly, but also in providers. They make estimates of both of those things that are, I would say, fairly conservative estimates, but are useful. And with those estimates, they come up with, that there could be some noticeable savings. But again, it depends on the design of the system. So I will just sort of make a quick recommendation. If more time is given to the task force, I think it would be very useful for the task force to hear from Connecticut Medicaid, which uses a program of what they call managed fee for service, rather than paying intermediaries, paying Medicaid managed care organizations, which siphon off some of that money. They directly pay providers, but they also do it in a way that it's managed fee for service, which has much lower administrative costs. Another suggestion, again, this is probably for the provider reimbursement tag, would be to invite somebody who understands hospital budgets from say Canada or Scotland perhaps, where they do it well, to find out how is it that they alleviate most of the potential downfalls that you might have using hospital budgets, because they seem to do it relatively successfully, and it would be useful to hear from those who have done it and know how to do it. I think anyway. So another part of my paper was to suggest that there are entities in Oregon who probably have much better access to data than I have. I'm using all publicly available data. For example, DCBS, which regulates insurance in insurance companies in Oregon, would have probably more up-to-date data on premiums paid in Oregon than what has been publicly published, but I'm not sure if they do. I would expect they would have to, but it would be useful to ask them if that's possible to get some data. A lot of the expenditures in Oregon on healthcare, public expenditures in Oregon that are not federal government, go through counties, and so the Association of Oregon Counties probably has pretty good data on their expenditures, and whether that's pass-through money or whether it is money that's come from the county taxpayers. And again, I did not spend a lot of time looking at that, but I did, there's some total numbers in there, but the details of that is not something I looked at much. There are, so that this relates to the second point on this slide, that to get useful enough data to actually devise a specific tax rates, which might be beyond the scope of this task force. But if one were going to do that, you would need quite a bit more data from these other entities that I think could provide that data. And maybe there's even data that they don't have now that could be provided in some manner, either with changes in laws or changes in effort. So one of the entities that needs similar sorts of information is the Sustainable Healthcare Cost Growth Target Work Group. So this is relating to that last point. So this was set up with in 2019 with Senate Bill 889, and the intent was to essentially get information about what are expenditures in Oregon and try to see if those expenditures go up by more than their cost growth target, which I think is 3.4%, but it might have changed from that a little bit, but it's roughly that annually. And if the numbers do go up more than that, they would try to do something to make sure they don't, try to address it in some manner to see that they don't. So in order to implement that sustainable healthcare cost growth target, they would need data on what expenditures actually are occurring. And so that they might have information that could help this task force in at least estimating, well, what's currently going on, so we know what could we expect with a single payer system. So I think that might be as much as I would need to say until I get more questions and more direction of what more you would like me to talk about. So, or what questions you would like me to try to address. So thanks for this opportunity, and I will certainly be happy to answer any questions that come up.
Great. So I cannot see everybody. So raise your hands or start talking and we'll figure out who this is. Who's got questions for Charlie? Dwight. Oh, I see a hand on your page, but okay.
Wait, you're muted.
Yeah, I didn't have a question right now. I may, but give me a moment to formulate it.
Okay. Looks like Sam does.
Yes, you can tell me squirming in my seat. Charlie, could you restate why the work of the SB 889 group will influence our estimates. Do you think that group will provide a significant reduction in healthcare expenditures that will be tolerated in the long run?
I don't see how they're going to. It's possible, but they could help this group because presumably to do what they're supposed to do, they would have to have current numbers about expenditures, and so that current expenditure data could allow this group to say, okay, well, here's some credible information about expenditures now. Then we can say, well, what savings could we expect with a single payer system, and therefore what new revenue is needed? So it's more the data that they might have, but possibly they could actually influence costs too. And I haven't yet understood why it's thought that they could do so in a very robust way, but perhaps they can. But most importantly, I think for this group is they might have very useful data, and they may not. I don't know how good their data is, so I haven't been able to judge that yet.
John Santa.
Yeah, the Oregon Health Policy Board basically has been tracking this idea for 3 or 4 years because of our concern about costs. And I should say that we probably have the state's expert on the call, Sarah Bartleman, who has really done a terrific job when it comes to 889. And if and when we want to know more, Sarah, I think, could answer a lot of your questions, Charlie.
Yeah.
You know,
well, hopefully questions that the task force has, yes. So not
Yeah.
my selection.
Yeah. Well, 889 is similar what several New England states have done. The first one to do so, I think, was Massachusetts, and it came about as a result of an expose in the Boston Globe about cost issues in, you know, those mega Massachusetts systems, especially in Boston, and pricing controversies there. And you know, Massachusetts landed on a let's make this more transparent, and let's provide a transparent goal for systems, knowing that if they don't meet that, we have a very powerful media companies who will hold them accountable. So they did this 3 to 5 years ago, I think. And, you know, it's resulted in some moderation of costs there. You know, other states are now pursuing other versions of it. It is dependent on the creation of a very reliable all-payer claims database. And 889 commits the participants and the state to doing that. And I believe, at least to some degree, that database exists now, but I'm not sure that everybody is participating. And one of the key challenges for the 889 effort will be, you know, to identify and, if needed, penalize the folks who don't participate, because it won't work if, you know, a system doesn't give their data. And some systems may decide the easiest thing to do is just opt out from the beginning and take the flak. I don't know, we'll see. You know, the industry stakeholders have come to support this. Some of you who had a chance maybe to listen to the Health Forum's webinar yesterday, day before, it was amazing to hear the Hospital Association say, we're totally devoted to Senate Bill 889. That's where our effort's going to be, and we're going to control costs through 889. We'll see. I think healthy skepticism is in order. It's voluntary, it's reputational. We'll see. I totally agree that we should be tracking it. There's going to be some important lessons learned there, and I think our effort may be better informed by both the data and what happens with those experiences. And I'm sure Sarah would talk to us more about that when
Thanks, John.
the appropriate
Can I
time.
jump in real quick?
Sure.
I think I
Sure.
agree with everything you're saying about the connection between these programs and these initiatives, and I don't want to disagree with any of that. I would just caution that the implementation timeline for the cost growth target program is a little bit longer than the task force timeline. So it is very unlikely that we will have meaningful data out of the program to bring to you to help with these conversations in the next couple of months. So I wouldn't count on that, but longer term, definitely keeping these initiatives tied together.
So if our deadline does get extended as we're hoping, would that much better align?
Let me give you some more detail then. We are working on collecting what we're calling the baseline data file from all of the payers in the state. We will be collecting 2018, 19, and 20 data. We hope to collect it later this fall. The data maybe, depending on the cleanliness and the quality of that data and how much massaging it takes, we are aiming for a report in the spring. So again, I think that's even a little bit beyond the extension. And I also want to just reflect the data lag by its design, the cost growth target program. The first data we're going to be getting is 2018, 19, 20, and it won't be ready for use until 2022. So not as helpful as it could be once we get into the full sort of regular reporting cycle.
Well, that's very helpful information. Thanks.
So if I can, is that intended to include the data from self-insured companies? Are they required to report, or are they sort of hope? Does it just hope that they will report, or what's going on with that?
We are requesting that they voluntarily submit data to the cost growth target program.
Okay.
Currently, a number of self-insured payers in Oregon voluntarily submit data to the all claims payer database. So we have some expectation that they will also voluntarily submit here, but we will not have 100% of the self-insured market represented in the program. We don't think that's going to be feasible.
Okay.
Great. Other questions from TAG members? Glendora.
Thank you.
Then
This
Dwight.
is for either Charlie or Chuck. I was wondering if Charlie, in your research, and did you look into how marijuana sales can be a source of revenue? And if so, based on what's generated here in Oregon, would that be a good source to consider if we have not considered that already?
So I was really looking just at healthcare expenditures. I was actually not looking at the revenue side of the question. I mean, I have looked at that, but that's not what this paper was about. And the revenue from marijuana is not there's not very much money there compared to the amount that's needed. It could be a source, but that's actually a separate kind of question as to whether or not that's a good source of money. So I will let it be at that.
Glendora, I can give you a number. There's about $100 million, give or take $50 million in marijuana sales in Oregon. If we had a 20%, if we had 100% tax on that, we would get roughly 1% of the revenue we would need. So I would say that if that marijuana is not a significant source of revenue for our committee.
Well, I mean, but every little bit helps, right?
So,
not where it would
Glenn,
fund the whole program, but is it worth considering?
well,
I would say
Glendora,
no.
I mean, Glendora, as we talked about at the last task force meeting, there's a number of sin taxes and small other sources that just don't add up to much individually or combined that we will make sure get transferred to the universal program. But that's probably not even enough to fill rounding errors, rounding of dollars. It's very little money. But it's important, and it needs to get tracked, and some very important programs like the ones that Cheryl is involved with rely on some of those funds, absolutely, but that not. So let's turn to Dwight. I think he had a question.
Yeah, and I don't know if you looked into this, Charlie, as you were talking about revenue, and cost savings. And one of the things and we heard a lot on the call yesterday with the healthcare call, there was a lot of focus on outcomes, value-based payment systems as a way to contain costs. And I, for one, have some skepticism about that. I think that, there's a lot of stake put in. We can really contain costs and change the system through those outcome-based measures. But I think also there's a danger to that, in that I fear we set up marginalizing even further some subpopulations that are already at risk, but because they present a big risk to the providers, they're less reluctant to take those population groups on in terms of providing care. I don't know if you looked into what other countries have done or other states around value-based payments, and is that anything you've looked into?
So I share your skepticism about value-based payments. Everything that's been tried in the U.S., well, almost everything, not everything, almost everything has not led to cost savings. There's been a very, very few special programs with value-based payments that have led to some cost savings. Almost all of the value-based payment programs that have been tried in the U.S. have led to increased inequities because of the very thing you mentioned. So those the experience in the U.S. would suggest that those have not been very useful, and almost no other country has used them because they don't have the same sort of system that we have that says, well, how can we try to get a little bit of savings out of this or that? And so very few other countries use them to a very large extent. I mean, they're used, every once in a while there's a place where they use them, but for the most part they aren't used. And I would say for the most part, the experience in the U.S. would suggest they have not been successful at either saving money or increasing equity. They've actually decreased equity almost always. There's a few of them that have done better than that, but most don't. So I guess that's my quick take on those.
So I have do other tag members have some questions? I have some questions from the report, from his memo. So can you tell me, I was sort of struck at the end, near the end, in a table on page 24, you have that the savings for clinic and physician office admin was only 40%. And I was sort of surprised by that. I was sort of wondering what that's based on.
So I based the savings estimates that I put into this report are based upon the Congressional Budget Office report that came out in December, and they're pretty conservative. I mean, there's been a number of studies on what savings you could expect at what administrative savings you'd expect in provider offices, and they do, a number of the studies do suggest that they would be greater than that. Most of the studies are done by comparing what happens in the U.S. in clinics and in physician offices with some other country. Often it's Canada, and there's still quite a bit of administrative costs in those offices, because you still have to do payroll, you still have to schedule appointments, you still have to do tax accounting, you still have to purchase all your equipment and supplies and stuff. So there's still quite a bit of administration that's going on. So yeah, there are studies that would suggest the administrative savings are greater than that, but the ones I used were from the Congressional Budget Office estimates. So that's where the numbers come from.
Other people have questions? And on the table on page 8, there's a table, and I was wondering if Medicaid's contribution to long-term care isn't included in that state and federal Medicare Medicaid role.
It
rose.
is. Yeah. Yeah.
It
so
is,
so
okay.
it is. And that constitutes about roughly 30% of the total costs. And the other piece with long-term care is that the state pays a slightly greater percentage of long-term care costs than it does overall costs. So.
Chuck, I see that Cheryl and Dr. Matt and Glendora, I don't know if that's a new question or.
No,
Okay.
Okay.
Okay. I'll have my
Okay.
hands up. So.
All right, Cheryl.
Okay, I just had a couple comments and then maybe a policy question. So first, the marijuana tax revenue is a lot to behavioral health, especially considering prior marijuana tax revenue was not used for behavioral health services. So it means a lot to us, and just ask the Measure 110 leaders and now Senate Bill 755, it means a whole lot to the behavioral health system. And any of those other taxes, as Chuck mentioned. The second thing, I think I've talked to Charlie about, fee for service versus value-based payments and anything in between, even way back during the work group times. And I think I probably disagree about fee for service, just having seen how poorly our members and other behavioral health providers are paid under a fee-for-service system. So I think I disagree with that. I understand the cost savings part of value-based payment as being, I don't know, controversial and maybe not equitable. I get that part. So I'm not trying to say that's perfect or anything, but I guess my question is, in terms of our final recommendations for this universal health care system, will we actually get into that whole argument of how it's paid for, or is it more about what it pays for and how much? Because the thing is, as I'm in the healthcare system, for behavioral health, it is definitely being, I don't know, pounded into our brains that we're moving away from fee for service. So I'm just wondering, in terms of if we get down the road on universal health care, how much of a lift that is to shift the ship around. If we were to try a different kind of payment system, something completely different in terms of showing value and outcomes. Because personally, I think just counting widgets is not very informative. And we're constantly having to make the case that what we do in the behavioral health system has value and works. So I don't know if that's a very understandable question, because I'm not sure if I understand it myself.
If I can respond just a little bit. So I think it would be very useful for the task force to invite Connecticut Medicaid, because they do things of the nature that I think might make some sense to Cheryl. I mean, another person to invite is Steve Campbell from Hawaii. He's a Hawaii psychiatrist who has done a lot of work in how do you pay physicians to get them to do the care coordination that's necessary. And there is actually, in a system that Connecticut uses and that he's working with in Hawaii, there is some amount that's paid by capitation, and there's also some amount that's paid by community-based to community-based providers. And I think that combination does seem to work pretty well. And I think it might make more sense if you actually had somebody like that who talked to the work group, because I think it would alleviate some of the questions that Cheryl has. I think
and I want to mention too. Yeah, just as a follow-up, I just want to mention that during the pandemic, our community mental health programs that had a capitated agreement with their CCO did way better than those who were relying on fee for service. So I agree with you on capitation.
Yeah, and it doesn't necessarily even need to be capitation. Some of it could be global budget for if there's an entity or organization that is large enough that you can fairly reasonably predict the amount of services required from year to year. You can do a global budget for things that aren't just hospitals. So global budgets can also help in that sense.
Yeah. And
yeah.
we certainly talked about global budgets and provider reimbursement.
Yeah. So they can be used for more than just hospitals, I think. So
So I actually just a couple of days ago was sent a copy of the Kemble paper on it, and I will promise this after this meeting to send it out to the full task force. And so I think the provider reimbursement tag should be the ones who really read it, most interested in it, but I think all of us are. So Glendora, you have another question?
Yeah. Charlie, can you tell me the comparison of healthcare expenditures on primary services versus chronic disease prevention?
I actually don't have those numbers. I might be able to find something about them, but no, I did not look into that for this purpose. So I can't really say anything about that right now.
Okay, no problem.
Yeah.
Any other?
I think Dr. Metz has had his hand up for a while.
Let's go to Chad first and then back to Sam.
Thanks very much, Charlie. I appreciate your remarks and certainly value your expertise as we go down this rather cumbersome road here. I have a couple of specific questions. One of them is regarding long-term care. Was the current spend down, which is done by individuals in the Medicaid program to get onto Medicaid long-term care, was that absorbed into the cost structure that we're talking about such that individuals no longer make a spend down? That's the first question. And then the second one was the cost of coding for Medicare thus was eliminated as part of the administrative cost savings. Is that correct?
I'll go to the first question first, and then I'll probably have you repeat the second one because I'm not quite sure I understood it. But this Congressional Budget Office did look at essentially eliminating the spend down so that everybody would be eligible for the sorts of long-term services and supports that those who are currently eligible for Medicaid would be. And so one of their estimates of their 5 different estimates of cost did include that. That one did also included higher pay for providers than some of the other estimates. So that particular one actually increased overall spending rather than decreasing. All the other estimates decreased it. But if you actually combine that with the lower provider spending, the cost would have been decreased. And there is another paper that does a critique of the Congressional Budget Office report that suggests if you use the Congressional Budget Office's own numbers for how much administrative savings there would be in hospitals and other providers' offices, then you could lower the payments to those providers enough that even with including long-term care as a regular benefit without the Medicaid spend down required, it would still save money. So there is the Congressional Budget Office report is very useful in the amount of information that you can glean from it. So
okay. So thank you. The second question just had to do with the administrative costs associated with Medicare participation. Presumably all of those administrative costs are eliminated if and when the Medicare program is part of the single payer. Is that correct?
I would expect so. I mean, there's going to be something required for providers to basically become providers in the system, but they're already providers in a system. So I would expect that most of those costs would go away, but I don't know exactly which of those would go away and which wouldn't. And I mean, the other parts of the cost that go away is everybody's eligible. So you don't have the eligibility determination cost. So that's a part that's a savings that you see. And that comes both in the sponsor or insurer side, where you don't have to determine eligibility because everybody is. And also comes in the provider side when they say, well, who's eligible to get care from us and who will be paid for it? Everybody. So that simplification helps.
Thank you.
Are there other questions? John will get the last one in, or no, Sam had his, so we'll let both of you go.
I'll defer
You'll be
to
brief
John.
and Charlie will be brief.
Yeah. We're getting late. I'll let John take it.
Okay, John.
Yeah. Well, Charlie, I just want to say that, I read your piece and I really found it helpful and wanted to understand it more. And this has helped a bit. And I would like to understand it, even more. Because I do think, it's like we need a spreadsheet at fairly big global areas. And on one side is expenditures, albeit estimates, and on the other side is revenues. I do think it helps in the discussion to know what some of these big chunks are. If we go down the road we're going, which I think we should go, we will have a very big bill in terms of dental, vision, and other sorts of things, especially for Medicare folks. We need to know that, and I think it helps to be explicit. And the other processes like this I've been involved in, eventually the team is focusing on this spreadsheet and its two sides. I think this is a helpful discussion, and to be able to compare, here's the estimates Rand used and why, here's Charlie's and why, and sort that out, I think is really important.
I think that really good point. Just be transparent about where the number, have a column on where the numbers came from or assumptions. I actually looked up and I couldn't find it. I didn't try to find it for this upcoming biennium, but for the current biennium from two sessions ago for PEB and OEB, that the total cost was almost $4 billion, 3.8 billion. And those are other funds, which are not general fund, not lottery, and not federal. And so, to your point that you raised, it's not, we have to decide on the accounting of it all, is that money we're going to say we get from the general fund did we have a category of current Oregon spending that will just automatically now go to our category, or what? And so, that comes from, and we have that with the local government stuff that you mentioned as well. So
the other just editorial comment, I think, we've had a lot of discussion about really what are provider reimbursement issues, but I can tell you and emphasize, there is no shared understanding of what the definition of a global budget is. Believe me, there's folks using that term all over the place in Oregon. I've asked many of them. I can tell you their definition is not what the next guy's is, etc. And the same thing is true for value-based payment. I would just remind us all that in my case, I'm a patient of, I believe, the most successful value-based payment system in the United States. It's called Kaiser. It is a value-based payment arrangement. It is a group model HMO. It is successful because of Permanente PC. While you may historically recall accusations about Kaiser's deficiency, and it certainly has some, I can tell you from a performance measurement point of view, it isn't even close. Kaiser outperforms everybody across the board almost all the time. So there's a huge spectrum here.
And I think one of the tasks of the task force is to get agreed on those terms.
Yeah.
So we'll let Chad, because this is his game plan. So go ahead, Chad.
Well, you know, I think the definition is very key. But I think as it relates to continuing to tailor provision of care and continuing to not tailor it with a sledgehammer, but tailor it with a very fine scalpel, it's very important to provide the sort of structure that allows those people that are most aware and in the trenches to be involved in that tailoring. And I think there's plenty of evidence that in the event that you don't do that, you don't open yourself up to opportunities for innovation and creativity in the delivery of care, and thus in the avoidance of cost.
Great. So thank you again, Charlie.
Yeah, thanks for allowing me to speak to you guys.
And so now I think I'm going to turn it over to staff to lead us on a little debrief of the task force meeting.
Yeah, thanks, Chuck. So this is really going to be a chance for a pretty open discussion here. Debriefing the task force meeting. I included the slides that we presented at the task force meeting, just in their exact state as they were last week, and then some takeaways. And so I'm gonna really quickly run through these, just remind us what is on them, and then get to our takeaways. And then I think we really just want to open the floor for people's reactions. If you've had subsequent thoughts about, you know, reflecting on the feedback from other task force members or things that you heard during the task force meeting, if you're having new thoughts after, you know, hearing from Charlie. And where we really want to get to today is figuring out some next steps for the work of this tag. So we thought giving folks a chance to process and kind of bounce some ideas off each other. And then hopefully by the end, we'll have a few next steps that we can take that you all kind of agree on would move the work forward. So go ahead to the next slide, Laurel. So this is just, you know, this is what we presented at the task force, you know, that these were sort of two sample options based on the conversations we had at the last tag meeting, whether there would be a package that had just payroll tax and income tax, or whether there would be a package that also included a sales tax. And these were some sample numbers provided. So go ahead to the next slide. So this is the one that just showed all three. And I know, you know, this again is an example, what a sales tax could look like, which is 8%. I know Dr. Metz and a couple of other folks have said, like, well, you know, where we really would want to go with this would be around 6%, which would be about 6 billion. So again, this is just to give some sample numbers, not to say this is the package that the task force or the tag recommending. But so there would be a sales tax component, payroll tax, whether that's a flat tax or whether that is a more progressive or somewhere in between. This was based on the information that Chuck brought forward last time from ITEP. And then there would be an income tax component. And these are just some examples of some really broad estimates on what different ways of raising income taxes might look like. So whether it's adding a top bracket, which would not bring in very much money, but certainly is an option, you know, whether it's raising everybody's rates across the board by a small amount or a large amount, or doing a more progressive tax. So that was the first thing that we put forward. And then the second one is the same thing, just without the sales tax. And so we kind of talked through that. And so in the third slide, you know, we had sort of estimates here. And again, if the sales tax was 6%, then it would be 6 billion. But, you know, I think without firm estimates of how much revenue oh, wait, go back. How much revenue we're trying to raise. You know, again, these are just really to give some broad picture here. So if you just go to the next slide, Laurel. So I went back and re-watched the task force meeting discussion on this topic. And so just wanted to pull out some of what I identified as being primary discussion points. The first one that came out several times is that there are plenty of reasons why all of these options will be hard. And so I just wanted to highlight the excellent quote by Dr. Metz that the badness has been heard. So there's a lot of recognition as to why these would be very difficult. And so I think as people bounce around from one option to the next option, I think just everybody getting kind of sunk in, right? Like there's plenty of disadvantages to be shared with all of these options. And so that's just kind of the scenarios that we all have to work with. There was a lot of back and forth and strong opinions expressed around the topic of the sales tax. People both in favor of and very much against a sales tax. And so I think this is something that, you know, both conceptually and from a number standpoint, the tag is going to need to grapple with a little bit more. There was two main things that I heard about what we are lacking. And the first one was, which Chair Goldberg brought up, and then a couple other folks echoed, this who pays analysis. So what would be the potential impact on different subpopulations, you know, families at different income levels, businesses, etc. And so that was something we talked about potentially being able to, you know, bring back around what would it mean for high income families? What would it mean for businesses who are currently paying for their employees' insurance, etc. So that was one thing that was brought up as that we were lacking that might be helpful in the discussion. And the second thing, obviously, is just better cost estimates. So those were two. There were other things mentioned, but those were two that I pulled out as hearing a couple different times. The other couple things were that it's going to be really important to get some clarity on the benefits recommendation in order to move this cost work forward. You know, you may remember that the task force actually did not take a vote on the benefits proposal, and we are moving forward with a separate group of folks to try to rework that a little bit and bring it back to the task force, hearing clearly that there may need to be some more limits in place. And then the last piece was just, it might be really helpful. Some people thought it would be really helpful to get some feedback from businesses here. So those were the points that I, you know, pulled out from the task force meeting. And I guess I just want to open the floor for folks to, you know, share your thoughts on the discussion at the task force. Have you had any new revelations or any comments on sort of any of these primary points that I've put up here? And we can start there and then kind of get ourselves into what would be helpful as some next steps. Les, I see you have your hand up.
Yeah, I just had a brainstorm. So the state revenue office, can't remember the name right now, they put out a report annually that breaks down taxpayer by quintile. And so I think, you know, in terms of when we go to pick out how is this going to affect families at different levels, we could possibly just choose, you know, the break points for those quintiles to see how that, you know, how it would impact the different groups. So that was something that rolled across my brain as you were going through this. So I just
Okay.
wanted to put
Yeah,
that
no,
out there.
that's really helpful. Thank you.
Yeah. Yeah, but that's a Department of Revenue report, annual one they do on personal income taxes. And so the Legislative Revenue Office, because they use the same data, also can model who pays different taxes. And then ITEP does that. And so I'll resend it around. The ITEP they actually call their report on looking at distribution of all states, all the taxes in all the states by state. They call it who pays. And so I handed out early in this process a two-sided piece of paper that has, for Oregon's tax system, who pays the various taxes currently by income level, by those quintiles. And that is something that's important to do. And then I guess I should maybe ask Les. I mean, I sent Les, because he raised this in an email to me, a copy of some testimony I did, a slide packet and a link to the actual hearing where I went over it in a rushed way. That shows the distribution.
Good, Chuck.
Did you think it was help? I mean, do you think I should share that with the rest of the committee, Les? That's my question.
I think listening to those hearings, I think gives some background, more background to how Oregon perceives different things. I'll say it that way.
That's a good way to do it. So I will send that out to folks. So it'll be a link to a audio file and then a PowerPoint presentation. So I'll send that out. So the other people have my thoughts based on the meeting was that our next steps, I think, is to do sort of at least half of what John was talking about, which is let's look at who's paying. Where are the revenues coming from now, right? And I think it's the details behind it's complicated, with also the stuff that wasn't in the it's complicated chart. I think it can get really confusing. In a state budget for an agency like OHA, they have personnel costs that's in the state budget. But then if you also go into OHA's budget, some of those, like the health insurance for our staff, is also reflected in the PEB as other funds that come into PEB, right? And so I think we have to figure out make sure we're not double accounting, and figure out what those are and the sources of them across, and look at, and the same with all the community mental health and behavioral health stuff, all of that. And so I think trying to come up with that spreadsheet with all the source, what's the program, when I go to the doctor's office, where's the money coming from? Some of it's coming from my premium, some of it's coming from Medicare, and some of it's coming from my out of pocket, right? And let's figure out those totals across the whole health system, and see and I think it'll also show us sort of numbers that, mostly it'll show us a lot of numbers that we don't have. Do others have other questions or comments based on the last task force meeting? We certainly sparked a good discussion at that last meeting. Our tag did. Chad?
Chuck, this is Chad. Yeah, I'm a little curious. I'd like to hear staff a little bit talk about the calendar a little bit. And so I like your suggestions, but I'm a little bit curious about how we shoehorn that work into the time that we have.
Yeah, thanks, Dr. Chadwick. I think that is potentially a challenge, for time and what I think I heard and what you're saying, Chuck, a certain granularity of data. I think what Chair Goldberg recommended at the task force meeting, which was a little bit more bird's eye view which was more revenue focused on who would pay, you know, based on revenue sources. That's something to me that feels more doable. This more in the weeds analysis, which sounds like it could be helpful. We just have to think through what's possible with the time and resources that we have available to us right now.
Yeah, I'm not trying to get that granular. I mean, I don't think I am. You know, I'm just trying, like, you know, it's come up a few times. Charlie mentioned it, and other times we've talked about, like, so how much of the state budget is going towards healthcare of state and university employees? Maybe it's the figure that's in the PEB budget. I don't know, right? And then and of that, I mean, if you're an employee like doing food stamp program and 50% of your time is paid for by USDA and costs, you know, then that's those dollars, those should be accounted for.
And Chuck, the figure of the I think it was 3.4 billion that is allocated to PEB and OEB, or something close to that. That figure was included in the calculations that we did to total the amount of revenue that could be applied to a universal program. So several meetings ago, we presented that slide that kind of enumerated the various federal and state dollars that we think could be transferred to this universal program, and it totaled 22.2 billion. And that number did include these state, the state contributions that you're referencing. It's maybe it would be good for us to go back and share that with you again and kind of try to identify if we feel like something's missing from that 22.2 billion figure. Does that feel helpful?
Yeah, did that have all the spending in local government and special districts and stuff like that?
It did. So this question around local contributions, I think, is an outstanding question. Nipper, is that an accurate characterization?
In that we haven't answered it?
Yeah. Yeah, so we can maybe, Chuck, after maybe a good next step is we could kind of follow up with you offline with that kind of list of the federal and state dollars that we feel could still be applied, how we reached that 22.2 billion, and then maybe identify what's missing to see if there's any other revenues that we could be capturing to contribute to this plan.
Yeah.
Am I hearing that accurately?
Yeah. Did it include schools? Did it include TriMet? Did it include the recreation districts? Did it, because, you know, the school districts are paying their folks via property taxes for the most part, I think. We're not going to get into property taxes, but
the state is paying, the state pays, I forget, it's a pretty significant percent of K-12 schools. So the state's actually paying a percentage of it too, right?
Right.
But we have to also add the dollars that are spent by the individual employees also.
Yeah.
Exactly.
But I don't think that we're saying, okay, school districts, you no longer need to raise those property taxes to pay, you know, the portion of your employee health that you've been paying with them. No, we would still expect them to do that, right?
Well, that's a really good question, because as I thought of that, I said, well, with these public employers, are we going to separate healthcare from employment?
Right, and what about the expectation vis-a-vis private employers? Are we handling government employees and employers differently than we're handling private entities?
So in terms of how we can try to tackle this, I mean, I do want to reiterate kind of Nipper's point of there are several kind of outstanding questions with respect to revenue methods, and some questions that we tried to outline here that we feel like we might want to dig into more with respect to the who pays analysis. Again, analyzing the revenue methods. We can certainly go back and try to revisit if there's any additional revenues that we can be capturing. I do worry that there is, to Nipper's point about this magic number, kind of focus. I mean, I do worry that there's this kind of sense that if we had all of the data, that the answers would kind of come forth from that data, and that if only we could figure out this magic number, we could figure out these answers. And so I want to make sure that, you know, if we go back this route, that we acknowledge that, you know, we're not going to be able to necessarily be doing some of this analysis with respect to the revenue methods.
John?
Does it feel like there's a priority, like a prioritization here?
John Santa, you're on mute. There you go.
Yeah. First of all, I think near term, i.e. for the report, I think we have to start realizing this isn't going to be wrapped up in a nice little package. That's not going to happen. And we shouldn't set expectation that it's going to happen. We have a lot more work to do. And, you know, while I agree that up to 20 billion could be needed, it might not. You know, for example, you've heard me before. I believe that we may be talking about a $5 billion additional benefit in Medicare. $5 billion. If there's no cost sharing, if there's no contribution, nobody has to pay their Part B premiums any longer. There's a much richer benefit plan. Those benefits are in areas like dental and hearing aids, where the population has no benefit at all now. So, I mean, how should that $5 billion be raised? You know, should that be raised by income tax? I don't know. So I find the most, I think it would be important for us to be able to say, from a revenue point of view, here's where we would go first. I would go to progressive taxes. I would go to the main plan and put that at the top. And, you know, identify where we would go. I do feel that we have not considered retained wealth. There is an enormous amount of retained wealth in this country. It's not going to be touched by some of the mechanisms we're talking about. And you know, I particularly feel that in Medicare, if we go with the approach we're talking about going, it's fair to ask Medicare folks who have that retained wealth to participate. So it's going to be very progressive. So, you know, I personally think that's important.
John,
that was my comments.
John, this is Chad, and I guess I agree with you, but I'm curious why you're suggesting that that be true of Medicare recipients and not be true of other recipients of the single payer system.
Oh, well, you know, just more of it is personal experience. You know, I mean, I've got to the age 70, and you know, I'm one of these guys that you know, felt I was too stupid to ever take much of a risk in the stock market. So, you know, put my IRA in safe places, and I look at what I've got and go, oh my God, I've got a fortune, and I've got a bigger fortune through the pandemic, and I'm ashamed of it because I really don't feel I did anything to deserve that much of a fortune.
No, John, I agree with you. The point I'm trying to make is that if you're thinking about progressivity, then it seems to me it should apply to the recipients of the system, regardless of their age.
Well, that's true. I mean, I would hope to sell it to Medicare folks that you're getting a much richer benefit. And because realize, since the Medicare folks aren't working, we're not paying FICA any longer. We're not paying Medicare any longer. We are paying income tax. But, you know, I'm particularly focused on that group, Chad. So that's
I understand.
others with comments or questions for next
Uh,
step?
If
Sam?
I can,
Go
sorry.
ahead, Chad.
Well, I was just going to say, if I could suggest a process, it would be that we begin sort of the buttoning down and the defining what's in and out of our initial report. And we also then begin generating the list of those things that will need to get worked on subsequent to this, either by an extension or some other process. And it seems to me it would be helpful to start bifurcating that and doing that a little more consciously at some point in time.
Sam?
Thank you. Following up on the exchange between Chad and John, we're talking about a tax that, as far as I know, has never been done in the United States, let alone Oregon, a net worth tax. That's pretty creative. I don't know if that's going to be any more acceptable than a sales tax, but we are going to have to get very creative if we're going to raise $20 billion annually and reliably. I agree with Chad that this net worth tax, we need to figure out a way to tax every resident, not just residents on Medicare. And lastly, I am concerned that this is such a huge amount of money that we're coming up with, that if we go with a payroll tax and an income tax and nothing else, the stability of Oregon taxes, already renowned throughout the United States as being unstable, will just fall over. I believe we need, in addition to a payroll tax and an income tax, something else that will provide some balance. Now, previously, I've been thinking about a sales tax, which is perhaps the most stable of the taxes we've been talking about. But either in addition to a sales tax or in place of a sales tax, a net worth tax would provide stability and diversity of revenue.
So I want to remind people from Chris Alanak's presentations, it's really difficult to do a net worth tax, a tax on wealth. There are what I would call surrogates. One of the surrogates is treating capital gains income the same as regular income, and Oregon does do that. And having a more progressive income tax that goes up with income helps with that. But there's proposals for wealth taxes have been made many times over the years, and no one's figured out a good way to do it. And I do think there are surrogates for it. There's, I think I'll just leave it at that. I just don't think you can do a wealth tax. But one of the surrogates for it is the IRMA payments in Medicare, right? The elderly people who have high income, why are they getting high income? Because they have wealth generating income. It's not just their house, right? It's not just their real estate they may live in. They have other investment income that's bringing in high income. They're not working and they're paying, and because of that, that's income on their wealth, and that's getting taxed. So that's sort of a surrogate for it. So, I would argue, because I agree with John, that, that's seniors should still have to pay the equivalent of their IRMA or something like that, which is written in a progressive way. You can't just having a wealth tax. There's a reason it wasn't on our list, and and I think Chris addressed that when he talked. So, Dwight.
Yeah, a couple things. One, to the point of putting together some kind of a report, whether it's interim report, final report. I think, and this speaks to the larger task force as a whole, but I think we have to be prepared that if we don't have an extension to our work, we're going to have an incomplete product. There's no way that we're going to be able to generate something that's got everything included and is really comprehensive. So I'm of a mind that we need to be prepared to say, we can't complete the work of the task force within this abbreviated time period. So I don't think we should expect that we're going to present a final product if we don't get the extension. So I think we just go back to the legislature and say, here's the work to date, but it's incomplete and this shouldn't be relied on. I think if we try and put something together that's not complete, it's setting up failure for ever getting a universal healthcare system established. So that's one point. Second one, and this is more back to a question about the payroll tax. And I know I confused, I don't know whether it was Laurel or Nipper, when I brought this up at the task force meeting. I saw confused looks on your faces. But when we look at an 8%, which raises, what was it, 8 billion, and the progressive 16%, which brings in 5.8 billion. So what I'm wondering, is there a way of looking at a combination of both, so that we'd have maybe a flat 8% tax up to a certain level, and then progressive 16% above that, that would bring in more than 8 billion? Does that make sense?
Yeah, that is something that could get modeled and calculated. Absolutely.
Yeah, and I would like to look at that to see what that would bring in, because I think there's value in having a progressive tax. I am all for that, but I think there's value in keeping a base level as well. So I would like to see what the results of that would look like.
Being a tax junkie, I don't want to cut this short, but I am interested in also bringing up another item that was on Nipper's takeaways from her valiant review of the last recording, that the issue of getting business people involved. And, we've gotten a lot of people have talked to us, Tom Sinsek and others, about doing more outreach. And I think this is a tag to be the one to invite the business people in, to have them talk about how they would respond to different revenue proposals. And we had that guy who has a family business down near Albany or Corvallis. That's a nursery business, and he talked about going to the nurserymen. I wrote him, I never got a response about following up, but I think we should connect with him and try to get the nurserymen in, try to get the restaurant and lodging in, try to get some of the really one or two examples of a self-insured people in. So I think that would be helpful. John?
Yeah, two things. It sounds like we're going to hear in the next couple of weeks how Joe Biden intends to raise taxes for his infrastructure. And given his promise to not raise taxes in people who have incomes under $400,000, I have to believe he's going to put some pretty progressive proposals on the table. It will be interesting to see. The other mechanism, there was one aspect to Chad's question that I didn't mention. I'm 70, and so I'm approaching the required minimum distribution. And for those of you who don't know, that means that I must withdraw a portion of all of my retirement accounts on an annual basis. I must, and there's a formula. And it's interesting, many of my friends, and I myself included, am thinking, well, what good causes should I donate money? Because I'm going to have to take out more money than I need. And what should I do with it? And because of that requirement and that process, I wonder if that's an opportunity to work with that population who's got to do something to direct some of those resources, or mandate to direct some of those resources to their healthcare system. So just wanted to mention that.
As someone who did nonprofit development, it's nice to hear that you're thinking that way, because that was always a when that got, it was that sort of a fairly recent thing in the law as far as giving it to a nonprofit instead of taking it. And, there's development offices in nonprofits who push for that, and it's, so that's great.
Chuck, I have a
Sam?
question.
Chuck, I just wanted to jump in really quick and kind of clarify something you said earlier before I forget.
Okay.
So you were talking about bringing some business folks in to kind of get their impressions or their reactions to various revenue methods that the task force might recommend, right? Is that what you're saying?
Yeah, I'd like to, right, that, explain to them our principles and talk to them about how we're not trying to run afoul of ERISA, and see that if we did certain things, how they would respond, for instance, they may say, yeah, do a payroll tax, but you can put it on us and that'll make us feel worse than if you put it on just on the employees, and we would fight it more, or we would fight it the same. And we sort of hear because we pass it on anyway. In our decisions of how much we pay someone. And so it would be interesting to sort of hear their reactions to that. They're the ones who are most vocal when we did 66 and 67 against the personal income tax side, because businesses have higher income people. So it'd be interesting to just sort of hear their sense of it, see how open they are to saying, yeah, we want to get out of the business of providing healthcare. The first person I'd bring in is John DiLorenzo, and I tell him, bring in one or two other business people who will sing your song or talk about it. Not necessarily about the sales tax, which I think he does a good job of talking about, but more importantly, the business case for universal care. In the audio I'm going to send out, I'm actually going to send out the full hearing, not just my portion of it. And I'll tell you where John starts, because I think his presentation to the Senate Revenue Committee back then was pretty powerful and it was like, God, if we had all heard that our first day, we'd be the most optimistic group for universal care.
So what I'm wondering is if it might be helpful to combine this draft of a who pays analysis as sort of a way to also help get feedback from some of these business folks. So because what I'm kind of envisioning here is like, with the different revenue proposals, depending on whether it's progressive or flat or whatever, if we had a sort of a grid of what we expect an impact might be on, your low income or working class employees versus your high income folks, like coupling that with getting reactions from the folks that you're talking about, particularly if part of the conversation is they want to know what would this mean for my employees? For us to be able to do a little bit of that framing ahead of the conversation might be helpful. It feels to me like it might be helpful, but I just want to put that up there.
I would like to support what has been said about recruiting business. First, I had to tune out for about 20 minutes, so I apologize. I agree with John's reaction at turning 70, and I'm wondering, where did all this come from and where are the charities can go to? And we should all realize this is not normal. Most people don't think that way, even people in our positions, which is why we should be checking with business people who don't have the luxury of giving money away. I think that the suggestions so far are, for the most part, good. John DiLorenzo has been a lobbyist for Oregon businesses for a long time. He's connected. I recommend we reach out to Associated Oregon Industries, which is the business organization for the largest industries. We make some informal outreach to the Oregon Health Leadership Council, which is also well connected with large industries. I think we should be careful about inviting small business people in to speak for themselves, because that tends to reflect personal interest in this rather than speaking for a community. We might be better off doing outreach to chambers of commerce, which of course are very conservative organizations, but we need to hear them. I would also suggest, lastly, that our attitude be, please invite them to come here and educate us and tell us how they feel, so that maybe we can change our minds rather than make this an evangelical program where they come here and we try to talk them into whatever we've been thinking about. That'll come later. I think the first goal is to find out, how do these variety of businesses, how do they think about this? What do we need to avoid before we even start? And where are the most fruitful areas we can go?
I think that's a great point, Sam. And I as far as small business, I'm suggesting we go to some sort of industry groups like the Restaurant and Lodging Association, which has a lot of small business members, or the Nurserymen, which is generally small business members as groups. But I think you're absolutely right about the conversation should be, we want to learn from you how you think about this.
Chuck, are you
Chad?
thinking this? Are you thinking this will occur before June?
I think it would be good if some of it could. I think it could help inform us about how we talk about. I think it will do what Sam suggested. It may get us to think of different things to put into our plan, but I also think it'll help us figure out how to talk about it too, and make sure we're addressing what issues we need to be addressing in our report.
One of the things that had been discussed in the past was the idea of eventual public hearings. And I'm curious about how this would relate to the notion of public hearings. I'm also curious about, as the head of the reimbursement tag, which is really not operational at this point in time, there is the issue of provider input as well. And I really subscribe to hearings as opposed to invited participants personally, because I think invited participants could make mistakes.
I have a reaction to what Chad just said. Well, back to what you said, Chuck. I think that John DiLorenzo would be an excellent first step that could probably be done soon, and it would give all of us a better idea of how outreach to that community. He will have a lot to say that will be useful to us. I'm also, unlike Chad, not a believer in public hearings, because I don't think people who have financial interest love to discuss their financial interests in public. And I don't think we will get the kind of input, useful, practical input that we need. Of course, all of what we're doing now is eventually public, but I would prefer to start small so that there's some sort of trust and intimacy that we can build with these people that assures them that they're really listening, rather than asking them to perform for a large audience. I might have overstated that.
Well, so everything we are doing is not eventually public, it's in real time public. And I'm not sure I understand Chad's differences between invited and public hearing. I think we have meetings. The reason I would like to do invite is if we just sort of say, we'd like to hear input and not target certain people to make sure they're there, they're just not going to show up.
It's probably a semantic difference.
Yeah,
Chuck.
it is probably a semantic. And it's also, I think, to explain that we're there because we want to do what Sam suggests, is we want to learn from you guys, more that'll help us in our decision. both reactions to our stuff, but also, you know, how do you think about healthcare, and what would you change if you were in our if you were on the task force?
Just a comment about healthcare employers. They are both large employers and healthcare providers. So it's worth considering the idea that you involve healthcare organizations that will allow you to speak from both perspectives.
Absolutely. Absolutely. They are, you know, in a community like Silverton, they're the largest or second largest employer, right?
Throughout the state of Oregon, other than governments, they are always the largest employer.
Right.
Except maybe Nike, I guess. I don't know.
So other comments? Do you think that's enough, Sarah and Laurel?
So we're thinking about, I think, schedule right now, and kind of what meetings we have scheduled now, and which ones we still need to schedule. We have a meeting the TAG has a meeting on the books for the 14th. So that's in 2 weeks. This feels like if there was a desire to kind of do this, some type of engagement with the business community, that feels like something that we might be able to pull together in May, send out invites, you know, line up schedules, that kind of thing. Does that feel like a timeline that would work for you all?
I'm curious about whether this is a task force decision versus a TAG decision.
Yeah, I mean, I will kind of reiterate that we do have, you know, we have talked about using a portion of the extension for targeted stakeholder engagement, both some type of public forums, remote public forums, and some type of targeted outreach to the business community, to providers, as you said, Chad, to other folks. I think I don't personally see a reason why that can't happen sooner necessarily. It feels like, again, you know, giving us a month to try to prep for this. I could also see why you all might want to bring this back to the task force. Those are just some of the thoughts going on in the staff chat box.
I think that we as a TAG are a little bit more nimble than the task force as a whole. So I believe what we've been talking about, we should take the lead. Chuck, I think you're the one, all of our outreach should come from you, from our TAG. So I suggest you take the lead. And as you see receptivity amongst all these organizations and people, if you can arrange them as, find out what their earliest times are, then you can come back to us and say, I can get this person or this organization 2 weeks from now. It wouldn't necessarily be a full TAG meeting, but it would be a focused involvement with whoever you can get. I like the idea of getting this done soon, because we have talked about so many topics in which we're wondering how we're going to be received. It would be liberating, I think, if we really got some real world feedback about what we can expect and where we should go.
And is this a whole package that they are reacting to, or is this something that's focused on the revenue side? What are the thoughts about that?
My concept, which I think you can consider, is when we approach these representatives of the business community, tell them we are designing a tax plan that will generate $20 billion a year in extra revenue. A good part of it's going to come from business, and we want to find the least painful way for you to make a contribution. Help us out.
Yeah, I would do it I would do more the way you first described it, which is tell them, make sure they understand our charge to come up with a plan. Say that we know it's in this very ballpark. It's a lot of money would have to get raised, and say, but how do you ask them more generally? How do they think about healthcare as an expense that they have? What they would like to see if the state was going to try to do a universal.
I agree.
And not just and to Chad's question, I guess I do want to know on the how to fund it and whatnot, but I am also interested in them saying, well, even if you did it the way I want to fund it, I'd be against it if you covered all visitors, right? Who are here for a day or day or more, right? I mean, I think we should hear from them the broader issue too. The issue of whether they're gonna. I assume they'll ask like John DiLorenzo has. So are you going to allow a business to have its own supplemental policy if they want to give their employees a Cadillac healthcare? They would be enrolled in the state, but then we as a business could give them supplemental things like that. Would that be allowed? I mean, so I'd like to hear what they think on the broader issues as well, but mostly on the how to fund it.
I like what you just said, Chuck.
And it could be in it, and I also could be as to Sarah's question about timeline or Laurel's. It could be that we could have a meeting where there's more than one in May or whatever. But if there's a couple people who say, yeah, I'm happy and I could come on these weeks in April, these meetings in April, we could, like we did with Charlie today, we could work them into an agenda.
I like that, Chuck, and I wouldn't lead with we're developing a tax plan. I think we're developing a revenue package that may include existing taxes and other revenue sources. But I think if we lead with we're developing a tax plan,
right,
we're going to shut down immediately. So
right. And I think we'll get insight into their feelings toward how much they pay for healthcare, their feelings towards how much of it does come out of employee pay pretty directly versus indirectly. I think we'll get input into their feelings towards different types of benefit packages. How have they made decisions on what insurance to provide or not to provide? There's going to be some industries and groups that are going to say, we don't provide it, and these are the reasons, right? And we can learn from that.
Chuck, I don't know if you can see my hand raised.
Go ahead.
I was just going to add in, can we bring in labor, the other side of the coin, like Oregon Educators Association? I think might be a good one to talk to. I know a huge percentage of my compensation is healthcare, and having drafted up budgets and knowing the benefits percentage that I work with within the community college structure, yeah, it's a huge percentage compared to the percentages that we're talking about here. And I also live in timber country in Roseburg and hear a lot of complaints about Canadian timber, and I tend to bring up healthcare as an issue and a cost driver for American made timber relative to Canadian made timber. I don't know enough about the timber market to really make all the arguments, but I think they might be an interesting one eventually to bring in to talk to about how they feel it's affecting their international competitiveness. Those are just two thoughts I've had, and I'm happy to try to connect you with OEA being a member, but I just want to be helpful in the ways that I can.
Thanks. And there's the private unions. I know, I think like UFCW, I think it has it. There's the unions that I know nothing about this issue have those union trusts, the Taft-Hartley trusts or whatever. And so, which none of us have discussed about how that would work and the interaction with that. So I think it would be good to hear from those in the labor movement who historically have stayed out of the some of them have been in the universal health care debates and promoting it, but there's some who've stayed out of it to protect their Taft-Hartley plans. And so I think we should hear from them.
So it sounds like we have a pretty good idea of how you all want to structure a May meeting. I'm thinking concretely here about there's a meeting scheduled, as Laurel said, in 2 weeks. And so as we think about how to best use the the tag time there, I think we could do, to Dwight's question, we could certainly have some updates about other iterations of a payroll tax. And I think we could do some high level of a who pays grid or analysis. But I'm wondering if that feels like that would be helpful for April 14th, if there are other things that folks feel like out of today's conversation, that would be reasonable and helpful for meeting in 2 weeks. I don't think, one other thing is that, we're also planning this benefits conversation, which will be happening around that same time. So I don't think there's going to be any new information from other parts of the task force to kind of bring to bear on this conversation by that point.
Chuck, is it your thought that we would have made a decision prior to bringing these people in so they have something to react to?
No, I not really. I like Sam's to the extent we've be gentle in how we describe what, that we have these three sort of very not set in stone ideas, but really it'd be a way just to hear from them and really make it asking them for advice and information and how they think about universal care and how it should be funded. It wasn't going to be funded by insurance, or whether they're, if they all came in and said, don't do anything to get in the way. We love the fact that we provide insurance. And if you do anything that those sneaky lawyers tell you to do, we'll sue you under ERISA and we'll fight you all the way and it'll never work, blah, blah, blah. I think that would be instructive, but I don't think we'll hear that.
Chuck, I can confirm you will hear that if you speak to enough of them. I have heard that language.
Well, so I'm open-minded, and I'd like to hear what more than the top level rhetoric. I want to hear how they view it and what seems to work or not work, and what they would like us to consider.
And then we would go back to a decision point.
Well, yeah, at some point.
I mean, I'm trying to understand the process, Chuck. I'm trying to see how this unfolds without becoming sort of more cloudy and confusing and more variables, and leads us into a process which is going to take a lot of work to crystallize. I'm just trying to understand how it's going to go.
I guess I would like to hear. I think it would help us in our decision point if we knew more stuff. So, I mean, I don't think we're going to hear all these business people come in and say, oh, we've been quiet all these years, but John DiLorenzo's right. Both his case for universal care and using a sales tax, he's right. And we would all support that. I don't think we're going to hear that, but, let's see what we get from them.
Thank you.
So to that end, I mean, do you feel like a meeting in 2 weeks is needed and is helpful, or do you want to hold off and hear from the business community?
I think we should meet, and maybe we can even get one or two of them at that meeting. So
that was my vision that all of us would be able to interact with the business representatives so that we all hear the same thing from the same person. So I would suggest, I would favor a full meeting with whomever Chuck can recruit to join us as soon as possible.
And so if we are not able, it's 2 weeks out. So if we are not able to get, you know, some folks that you guys want to hear from in 2 weeks, I'm just trying to get a sense of, is there other things that are helpful before that conversation or not?
I mean, Nipper had thrown out this who pays analysis and potentially digging in further to a payroll tax that could be flat and progressive, a combination that Dwight proposed. Would it feel helpful for staff to kind of dig into those 2 items in advance of April 14th?
I think so.
Sure.
Okay, so we can do that. And, you know, Chuck, we can talk with you separately offline about who we, you know, might be able to try and get in here for the 14th so that we can maximize everybody's time.
And I'll get in touch with the fellow at ITEP who did the main analysis and numbers and see if he could do 1 or 2 versions of a more blended one that's still progressive.
Can we hear from Mr. George? He's had his hand up.
Oh, Warren, you have your hand up?
Mute here. Yes, can you hear me? I was just waiting for opportunity for public testimony.
Yeah, okay. So do you have enough, Sarah and Laurel, to go? Because I was wondering I wasn't sure who signed up for, I didn't see Warren's hand up. Who else? Do we have other people signed up for? Okay.
No one else signed up.
This is Lee Mercer. I think I'd like to put in a couple of minutes if possible.
Okay. So why don't we turn to Warren?
Okay, thank you. I've been listening over the weeks of the discussions and listening to what information people wish they had and looking for ideas of how to structure things. And I intend to submit to you within the next few days my own research on who pays and how actually with graphical schematics showing how money is spread out across income, wages, health of people, and how different funding schemes would affect that. And I will also propose some ways that you can lower your tax by retaining the more of the money that's being currently spent. So I just wanted to say that that's coming to you, and I hope you will be able to take time to look at the information.
Okay, that's great. So Warren, you should send it to Laurel or Sarah Nipper. If you don't have their addresses, I'll send them to you, and then they can get it out to us and other task force members.
I will do that.
Sort of best way to do that and get it on our site, whatnot. Thank you. Lee?
Yeah, thanks for all the work you guys are doing. I'm celebrating this week because I've now gone back and listened to every tag, all the tags, every meeting that's on tape in the entire task force, and I'm caught up today. So I was just going to, and again, I worked for Chuck for about 6 years or so at OCPP, and I've worked with Sam for a number of years, and I know better than to disagree with either of them. But I would warn a little bit, caution in terms of moving forward in terms of engaging businesses at this point in the process, in that leading with asking how should we pay for this before we can explain what it is we're paying for may be a little difficult with business owners. I would tend to agree that you might get John DeLeonardo or some other folks that maybe you already know are fairly friendly to where we're going and understand where we're going, as opposed to just getting some random people in the room. So I'm just warning a little caution. For many years, I worked with Main Street Alliance, organizing and talking to businesses all over the state, surveying them, and then getting them on board on a progressive agenda. But then when we were, say, working on paid family leave with the legislature, a lot of meetings were put together, but you didn't put them together before you had an outline of what paid family leave would look like and how it would benefit everybody, before you start asking them how to pay for it. And just warning caution on this process. And I have some resources. I've done outreach to the state chambers of commerce, and I have a fairly updated spreadsheet of their information, which takes time to do because they turn over all the time, and other things in terms of resources further on when you want to talk to more businesses. When we get into the public comment part of this, possibly in the fall if the bill passes, there's some ways to go about this where we can sell businesses in a way that brings them in rather than alienating going out the gate by saying, well, let's see, how can we pay for this? Anyway, this is just a word of caution in dealing with businesses. So that's it.
Lee, thank you very much for making that point. To quote Ronald Reagan, I misspoke earlier, and I think you and Chuck are right in your approach to first approach to businesses.
So any other comments or questions from TAG members? Should we call today? Oh, Citizen Consumer Advisory Group Committee. Are there any questions for them? Nobody. Everybody looks tired on this beautiful sunny afternoon. Okay, well, I think that maybe we can end a few minutes early then. So thank you, everybody. Stay safe, wash your hands, keep socially distant, all that stuff, good stuff. I'm getting my second shot tomorrow morning, so hopefully it won't affect me like it affected my wife, and I'll be available for a different TAG meeting tomorrow afternoon. So
I'm doing the same thing tomorrow, Chuck, so looking forward.
Wow, so is Margie. Tomorrow's the day for the vaccine.
that's great. That's great.
Chuck, thanks for your leadership here.
Well, thank you. Take care.
Thanks,
Bye,
everybody.
Bye now.
Bye.